right, so good evening. We'll take it slow these first few minutes, so hopefully some other folks trickle in. But good evening, everyone, and welcome to a really exciting hour webinar that we are bringing to you, the lipid guidelines and a deep dive into EPA, presented by my friends and colleagues, the fantastic Viet Le and Laura Ross. Very honored to have them present. They're both content experts in this field for sure. So I know that we're all going to learn a lot over the next hour. I did want to take a minute just to kind of dovetail onto what Laura was just saying in terms of the Association of PAs in Cardiology, APAC, hosting this event. And of course, we do want to thank our lovely sponsor, Amarin. But APAC is a phenomenal organization. We have all, Viet, Laura, and I have been a part of it for a long time. And really, you know, the three sort of pillars are advocacy, education, and networking. We would love to welcome you all as members. And there are lots of opportunities for contributions in many different ways in terms of peer-reviewed journals and social media and, you know, further kind of committee involvement in national societies, things like this. But that's a little bit outside the scope. But please do check us out. If you're not a member, we would love to have you and get to know you a little bit better. So again, thank you and welcome. We have about 21 participants, which is fantastic. And again, I thank our sponsor, Amarin. What else do I want to say? So please do utilize the chat feature. I'd like to make this very conversational, and I'll be sort of moderating this evening and looking through the chat and interjecting, you know, questions, but there will be a dedicated Q&A at the end of the two presentations. So please keep that in mind, but feel free to chime into the chat and I'll sort of log things as we go. And with that, I think we will kind of dive right in. I'd like to first present Viet Le, again, excellent friend and colleague. And let me read you a little bit about Viet. So Viet obtained a BS in exercise science / athletic training in 2001 from the University of Utah and obtained a master's in PA studies in 2004 from the University of Utah School of Medicine. He's practiced 7 years in occupational medicine, 8 years in cardiology, and since 2012 has held the position, as cardiovascular scientist within the Intermountain Heart Institute Cardiology Research Center. His primary focus is cardiovascular research, collaborating across multiple cardiac subspecialties and a vast array of trials and studies. He sees patients in a general cardiology practice. He's also part-time faculty at the Rocky Mountain University of Health Professions PA program and is currently working on a doctorate of medical science, and of course is the president-elect for APAC with a many full-time jobs and a family and so on. We're sure Viet doesn't sleep, but he's here this evening to impart some wisdom in terms of lipids and deep dive into EPA. So welcome, Viet.
Thank you. And actually, I think, Laura, did you want to lead out first on the lipid guidelines? I'm so sorry about that, Amy.
Pardon me.
No, that's okay. We can we'll do it as a get to know the speakers, and then we'll move over to Laura.
Then please let me read about Laura's bio, and forgive me. I got very excited, so forgive me. Laura Ross, who is the current treasurer for APAC, as she mentioned. She's been a cardiology physician assistant since 2004, when she graduated from Rosalind Franklin University of Medicine and Science in Chicago. She works at the Park Nicollet Heart and Vascular Center near Minneapolis, Minnesota, the variety offered by Rounding in a suburban hospital and clinic, as well as outreach to a more rural site, has provided opportunities to be involved in a variety of cardiac specialties. And she's got some wonderful stories I hope she shares with us tonight. Her specialties include prevention, women's health, and coronary disease as some of her favorites. She is a certified clinical lipid specialist, which is phenomenal, quite an achievement, and recently started a Plant Forward Cardiology Clinic program. She says it's been an honor to represent PAs on the ACC Interventional Leadership Council, opportunities to advocate for patients on the Hill during legislative days, present at conferences, and contribute to journals have been career highlights. She enjoys spending time with her 3 adorable little girls and her 2 rescue dogs. So forgive me, Laura, please kick us off with the guidelines.
Well, thank you for that generous introduction. And Viet is the keynote speaker, so I'm glad you started with it. But I will go ahead and share my slides here, just a minute. Yes, we're going to talk about the lipid guidelines, and the objectives today are to review the 2018 guidelines, as well as the primary prevention update from 2019, and also review the medications we can use to decrease cholesterol, but not only the numbers, also the cardiovascular risk, which is really what we care about at the end of the day and our patients care about. So we had a chance to briefly review this on our last webinar, but we were just so optimistic of fitting in the heart valve guidelines as well as the prevention guidelines. I wanted to just take a little more time to get into these, especially for those of you who weren't able to join us on our last webinar. So in 2019, ACC and AHA came out and said, let's really talk about some of the changes we need to address with patients to assess their risk. So let's start with estimating their 10-year cardiovascular risk. Look at their risk enhancing features. Let's really focus on nutrition because food as medicine can really work. We know the Mediterranean diet, the DASH diet, vegetarian or vegan foods, all of these have benefits and studies that support that and really advocating this for our patients. It no longer does anyone good to just say, follow a heart healthy diet. Patients don't really know what that means. So really get into that data with them. And then also talking about obesity. So we talk about lifestyle changes, give it about 6 months, but then that's when I start to talk to patients about the risks of not being more aggressive versus the risk of being more aggressive, even up to bariatric surgery or medications. You always want to touch on physical activity. You know, as PAs, we often have many more touch points with patients than the doctors that we work with. And so taking that opportunity at our frequent visits to really bring up these lifestyle changes. I think what's really exciting in the last year or two is that medications for diabetes have shown a lot of benefit for cardiovascular disease. And so really looking at and sending a note to primary, or if you're in an institution that has already adopted this practice, considering SGLT2 inhibitors and GLP-1 receptor agonists. Looking at their lipids, we're going to take a deep dive into this for primary and secondary prevention, but especially if it's over 160 or they have a family history of early heart disease, we should think about starting statin therapy. Looking again at the blood pressure goal, again, is less than 130/80. Address tobacco use at every visit. And then, of course, what's newer in the guidelines is talking about aspirin for primary prevention. Someone's over 70, really probably the risks outweigh the benefits unless they're really high risk. And then 40 to 70, we probably don't want to think about it unless they have a lot of risk factors because we know there's a higher risk of bleeding. So now we're going to dive into the 2018 guidelines a little bit more, which it was endorsed by all of these wonderful letters and societies. And what I like is they really boiled it down to who should be on a high dose of or maximally titrated statin. And it's these three groups for sure. Someone who has atherosclerotic cardiovascular disease, very high risk are people that are vasculopaths who've had blockages in their carotid arteries, in their coronary arteries. Those you want to be really aggressive. And if their LDL is over 190, we know that that's a kind of a genetic marker for a familial hyperlipidemia. And so let's go ahead and be real aggressive with statin therapy. And for these high-risk patients, if their LDL is over 70, despite maximally titrated statin, think about adding Zetia first. We'll talk about the studies that led to that guideline. If it's still over 70, then think about a PCSK9 inhibitor. However, the cost effectiveness is currently a little low, although it's coming down, and the long-term safety data is not as robust as our statin therapy. Moderate dose, we really want to be thinking about with patients with diabetes who aren't too young, aren't too old, and if their LDL is over 70. Start with moderate intensity. However, if they have multiple risk factors, it's very reasonable to talk about the risks and benefits with our patients about, would you be someone who should benefit from more aggressive therapy? So let's go back to primary prevention. So if our patients are between 40 and 75 years old, we start with this first green box, shared decision-making, of course, lifestyle changes. I'm really big on talking about using food as medicine and whatnot. And then we bring out that 10-year cardiovascular risk calculator. And if it's over 7.5%, we're going to start talking about statin therapy, especially if they have risk-enhancing factors. And we'll talk about what that means here in the next slide. But if their 10-year risk is over 20%, they have a very high risk of having a heart attack or stroke in the next 10 years. So then we're going to recommend statin for sure. This next slide down here, we'll talk about coronary artery calcium scores. I say if uncertain, and typically that's if the patient's uncertain. I usually have my bias towards statin therapy if someone's starting to have a risk of greater than 7.5%. But if patients are adverse, we have tools, risk-enhancing factors to look at, as well as the calcium score. And we'll talk about that more in a minute. So you calculate the 10-year risk. I like the cvriskcalculator.com, plugs in what their risk factors are. And the ACC also has a tool that does this. It sounds like Viet, even in his electronic medical record, has a tool that can kind of pop out this number in the note. And then you talk to patients. If it's under 7.5, it's reasonable to consider risk enhancing factors or weighting or a calcium score. But if it's over that, what do we do next? So what are those risk enhancing factors that might favor statin therapy? Certainly if they have a family history of premature atherosclerotic cardiovascular disease, that's going to make us think there's some genetic abnormality, maybe extra sticky cholesterol, so to speak, small dense LDL particles. If their LDL isn't, not only over 190, which is high risk, but over 160, chronic kidney disease, we know those patients are at high risk. And then some of the imbalances in hormones, so to speak, like preeclampsia during pregnancy or premature menopause, that estrogen protects us for so long, but if there's these swings, then sometimes that can lead us to the same risk as men for heart disease. Chronic inflammatory disease, as listed, that chronic inflammation can be hard on the heart arteries as well. And then high-risk ethnic groups, particularly patients of South Asian descent, have increased visceral fat and an average of 10-year earlier onset of coronary artery disease. So we want to be even more proactive in talking to those patients. Persistent elevation of triglycerides, we'll be talking about that in particular. If it's over 175, we know that's a risk enhancing feature. So not over 500, which is kind of what the norm was when I started training. That's when you start to worry, but we now know that this is a risk. And then elevated biomarkers that you can check in some routine labs. We'll talk about what those are here in a minute. And then the last one is the ankle brachial index. So this is a surrogate for claudication, peripheral vascular disease. Not only if it's low, but also if it's high, that could indicate non-compressible arteries. And this just adds fuel to the fire is how I think of it and how I explain it to patients. So those lab biomarkers are going to be the lipoprotein A. This is kind of an extra protein that makes the LDL more sticky, so to speak, or the cholesterol more sticky. And under 30 is normal. And it's certainly if it's over 50, we're starting to think patients are at high risk. Now, there were some medications that were lower lipoprotein A, like niacin, but it really didn't pan out that it prevented the things we care about, strokes and heart attacks. So I've been de-prescribing niacin for a while now to just make sure that patients, it's not just helping us feel better, but does it actually help improve outcomes? We know this is just a surrogate for risk. Apolipoprotein B100 is a concentration of all the atherogenic particles. So again, we know all LDL is bad, but if they're small and dense, they're worse than bigger, more fluffy particles, so to speak. And statins can lower that number. Again, if it's under 130 is normal, but if they have heart disease, thinking of getting that even lower under 80. And then the last one I think really hits home with patients that I'll check is the hsCRP. So as many of you know, this is thought to be sensitive to inflammation in the coronary arteries. Now it can also go up for other sorts of inflammation. So we recommend 2 measurements to confirm if it's high. Under 2 is normal. I'd say over 5 or to 10 is probably something else going on, a tooth abscess or sinus infection. So go ahead and recheck that. But these are all ways we can help talk to patients about what their risk is, even if they don't understand or agree, or it's a little bit of a gray area for if they would benefit from statins. So next we're going to talk about this middle box. If we're uncertain, use a coronary artery calcium score. And we know if their score is 0, unless they have diabetes or a family history of early heart disease or they smoke, a score of 0 offers a lot of protection. In fact, if it's 0, we probably don't need to consider a statin for another 10 years. So patients love when it's 0. When I get it and it's not 0, they are mad that they got this test, but I think it does help us with risk factors. If the score is 1 to 99 and they're over 55, we want to use using a statin as favor, and if it's over 100, or they have more calcium than 75% of their age and gender matched cohort, then a statin is indicated. And this is how this got into this flow chart for the guidelines. There's no false positives. You can see here on the CT scan that the calcium just lights right up. We know the radiation amount is similar to a mammogram. There's no contrast. It's about $100 out of pocket. Often flexible health spending accounts will help cover this, but it's going to be most accurate for men that are over 40 and women over 50. And that's because it does take some time to build up cholesterol in your arteries, and then your body forms a little cap of calcium on top of that that can light up if it's there. And we use this looking at the MESA study. So they looked at about 5,500 patients without any cardiovascular disease. They weren't on any medications. And out of all of those, there are 256 events. Anyone with coronary calcium had 79% of the events, and half of those events were patients with CACs over 100. Therefore, there was an 18% absolute event rate over 10 years if it's over 100. It's kind of similar to our 10-year cohort equation that says if it's over 20%, get a statin. If the CAC is over 100, we would certainly recommend a statin. And then they looked at this more with the data from the Jupiter trial and MESA review, and were able to come up with, if the CAC is 0, the 5-year number needed to treat with a statin to prevent one cardiovascular event was 124. If it is over 100, the number needed to treat is 19 to prevent endpoints that we care about, strokes or heart attacks or revascularization. But keep in mind, if patients are symptomatic, even if the score is 0, you still want to get a stress test. This is really a risk stratification tool for a coronary calcium score. And then, I don't know if I had a chance to review this at our last talk, statins, interestingly, will increase the calcium score. As they lower the lipid core, it concentrates the calcium, and it will look like patients have more calcium. And then they're like, why are you making me take a statin? That score has gone up. So I don't order a second one. It's really kind of a one and done thing. And then Viet's going to go over some great data from statins, but I just love this slide that we know the biggest side effects are preventing heart attacks and strokes. So I'll let him talk about the numbers there needed to treat and lower the residual risk. But lastly, I'll just wrap it up with talking about the Improve It trial. My institution was part of this trial looking at adding Zetia or placebo to simvastatin for patients who had acute coronary syndrome. And we know that LDL came down 20 to 25%. The number needed to treat was about 50 to prevent the primary endpoint over 7 years. But the more risk factors patients had, the number needed to treat started to go down. In particular, patients over 75 and who had diabetes, that was a much lower number needed to treat. And so I like to think of the CHAS-2-VASc score that we use for AFib. All those risk factors are other points you can use to see if patients are going to start to benefit from adding Zetia. And part of it is it the absolute reduction of the LDL that just lower is better, or was it some mechanism of Zetia that made that absolute risk reduction with adding that to simvastatin? And similar side effects. So well tolerated, it's generic now. I think that's why it came before in the guidelines than PCSK9 inhibitors. Now, as you may recall, PCSK9 are these purple Pac-Man guys who go around and attach to LDL receptors in the hepatocytes and kind of cause them to degrade. We like a lot of LDL receptors because that's what sucks the LDL cholesterol out of the bloodstream and helps lower it. So if you make a monoclonal antibody to those PCSK9 inhibitors, you start to have more LDL receptors that are available. And in fact, it could lower the LDL more than 50% in 3 months. The average LDL was about 30. There was a 25% relative risk reduction after the first year, although the absolute risk reduction was not as impressive for me at 1.5%, considering the cost of some of these medications. Again, the number needed to treat 74 patients for 2 years to prevent one cardiovascular death, MI, or stroke. And Viet's going to go over some other data about PCSK9 inhibitors. But I'll end our transition to Viet's great talk talking about the Reduce It trial. So this was looking at Icosapent Ethyl or Vascepa, over 8,000 patients with cardiovascular disease or diabetes and another risk factor. And they were given 4 grams of EPA or placebo. Everyone was on a statin. So this was real life. Most of our patients are on a statin. The average LDL was not high, 75. Triglycerides, 150 to 499. 5 years later, there was an absolute risk reduction of 4.8%, which means the number needed to treat was 21 to avoid one primary endpoint in about 5 years. So really exciting data there. We also saw there were lower CRP levels, or C-reactive protein for inflammation. There was a little more AFib, but no significant increase in anemia or hemorrhagic stroke. So just trying to balance those risks and benefits when you're thinking about adding this medication. And the National Lipid Association, which Viet and I are also involved in, came out with a statement in September 2019 really saying we need to consider this for high and very high risk patients to really help lower that residual risk. If they're 45 or older with disease or diabetes requiring medication, and one additional risk factor, triglycerides, not particularly high, 135 to 499 on maximally titrated statin, with or without ezetimibe, consider adding that medication. And we have a couple trials that Viet will go into. I want to just highlight the main points of this slide is that GELIS and evaporate, as well as reduce it, all showed significant benefit. Even without a lot of triglyceride lowering, cardiovascular outcome benefit when you looked at pure EPA. This is compared to the vital and strength data that used combination of EPA and DHA. We did not see a similar benefit, and they were lower doses, particularly in the vital trial, looking at primary prevention in particular. And so some people think, well, this kind of negates the positive EPA data, but as Viet will review it, we're really looking at oranges and apples here when we look at these trials. And I'm excited to look at the RESPECT EPA study that will come out in 2022 to see if we can have similar results like we did on the Reduce It trial. So with that, Viet, I'd love to pass the torch to you so you can give us a deep dive into the EPA story.
Okay, so let me see here. I will share my screen and hopefully you can see that now. Great. Okay, so yeah, lipid guidelines and a deep dive into EPA. I mean, Laura did such a fantastic job of teaching us and educating us on those guidelines. So, you know, the objectives, again, for tonight, she went over the guidelines there, those elements that are required to look at the ASCVD Risk Calculator and input those to develop a score. Part of what we'll look at is, you know, developing an evidence-based therapeutic plan for lipid lowering, although Laura already did that with regards to statin therapies and introducing PCSK9 and ezetimibe. But hopefully you'll come away with learning how the omega-3 cardiovascular outcome trials shape our current knowledge, and then identify and know what patients where omega-3 therapies may optimize risk reduction. So the lipid guidelines, I will be giving a talk a little bit later to our local PA group about this, but, you know, have we evolved? Maybe. There's been so many different changes with the lipid guidelines, and I have to laugh. Actually, this is a little distracting for me because it just makes me laugh while looking at it. But knowing that each time in the last two updates, the guidelines as it was provided by ACC/AHA were almost behind at the same conference that it was reported. So just know that the 2018 guidelines was provided just prior to Reduce It being reported out at the same conference, which gave us a whole new therapy. Of course, the data was not available for the 2018 guidelines. So it's always interesting. I always like to come back to, you know, what does moderate and high intensity mean in terms of statin therapy? It's important. It's important for us to recognize that the guidelines took away some of the targets that we're used to in ATP3 and then in the 2013 guidelines, suddenly we really didn't have any targets. But the data is really consistent in that we look at high intensity, greater than 50% or equal to 50% reduction in LDL, or in moderate intensity where it's 30 to 49%. So just shy of a 50% reduction. But there are only two statins that fall into this criteria here, atorvastatin 40 and 80, and rosuvastatin 20 and 40. Everything else is moderate intensity or low intensity. I do this because don't start there. Don't start there. Typically, if you're thinking of someone that has risk, start with the dosing that they need. You know, there is some idea to start low and go slow with regards to myalgias and et cetera. My experience has been that patients tolerate these very well if educated well on the side effects and nocebo even. So as a rough guide, lowering LDL levels of 1% give an approximate 1% reduction in risk of ASCVD. But we'll see that this doesn't really hold true all the time, or else if you had a 50% reduction with a PCSK9 inhibitor, you would see 50% relative risk reduction. So it doesn't necessarily happen like that, but across large groups of people, that's what we see. And really the caveat here is the higher the baseline LDL and the lower you get it, that's really where you see a lot of the reduction. So let me talk about that PCSK9 inhibitor, and we'll use alirocumab in terms of the Odyssey trial. It was nearly 19,000 people, but the cohort was a group that had just had an acute coronary syndrome within 12 months of enrollment. It's fascinating to recognize that 90% of them were on high intensity statins. So at least an atorvastatin 40 or rosuvastatin 20. And so hopefully that last slide brings that to the fore in terms of high intensity. Their LDL was greater than 70 in terms of the criteria, but most of them were between 73 and 104. And this is the best part. I mean, they achieved a reduction of 54.7%. So as you follow along the placebo line here, those folks stayed at 100 milligrams per deciliter. Look at this fascinating drop, just boom, right within that first 4 weeks here. And then going forward that's not the weeks, that's months here, first 4 months as you drop down. And it's fairly stable over time as you dose this. But you get, from 104 down to 53 milligrams per deciliter, again, 50% reduction, you're thinking, wow, maybe we'll see a 50% reduction in events. But that's not what happened. So this is the same over on this side. I point you to their outcomes. And here's the placebo line. And you can see that along here, MACE events go up and up and up. And then years from randomization, so on drug. And it doesn't really separate until you get out to about 12 months, which you kind of expect when it comes to coronary disease. It's a slow fuse, sometimes really fast. But what I point out here is that LDL, we're focusing on statins, then we add, ezetimibe, we add PCSK9 inhibitor, we're trying to drop these LDL down as low as we can go. And even here, when we've achieved 53 on average, there was still a cumulative of 12.6% events at the 36-month mark. And that's annualized to 4.2% per year. So just kind of put it in perspective, primary prevention, if you've done an ASCVD risk score and they're greater than 20% or at 20% for 10 years, that's 2% annualized risk. So these are really sick individuals who have high risk of events, even after doing everything you can to reduce the risk. So it's important, but it points to residual risk. LDL is not the only thing to treat here. And as Laura pointed out, we have a lot of things that add fuel to the fire, looking at LPA, looking at HSCRP in terms of systemic inflammation, your ApoB level, etc. In this case, we look at triglycerides. So I like this. It's a little busy. I apologize. We'll start over here as I discuss the primary prevention slope. So follow this red line and you'll see at the bottom the LDL achieved in each of these trials and the event rate. Okay, so of course, as you go up, the events go up, and as you come back down to 0, hopefully you're reducing risk. So WASCOPs, I mean, look at how high their LDLs were at enrollment. And as we get to each of these trials and push LDL lower and lower and lower in terms of achieved LDLs, the event rate also drops, but it's fairly flat. And I think that comes to ASCVD risk scores. We're trying to estimate risk. I'm a proponent of coronary calcium, where then you identify disease. And the idea is to understand the amount of disease and the disease burden. But primary prevention, if you're guessing, then this is what happens. When someone has had an event and you start treating their LDL, well, here's the 4S trial, the famed start of statins here. As we start heading downwards, you can see that there's a steeper benefit as we drop LDLs down. And it's linear. It doesn't really stop through here. So if we added Fourier which is evolocumab, and alirocumab for the Odyssey trials, it continues to go down. I got news for you folks. Fourier pushed people to less than 10 milligrams per LDL, or milligrams per deciliter, and there's no problems with it. They have not had any adverse events with keeping LDLs that low. So on a secondary, there's, again, no bottom end to benefit. Lower is better. But the caveat is that it does make a difference at where they start on their baseline LDL as you push them down lower. So maybe some of you might recognize this famous scene in Friends. I don't know if some of you were born. I was definitely born and around by 1999, but this is Ross trying to have the officer and Rachel help him move furniture up the stairs. Pivot, pivot. So we're going to pivot from LDL. We're going to move away from this idea that it's the only thing that we treat in cardiovascular medicine. So what's the evidence for omega-3s? Just know that observational studies kind of started this off, and quite by accident, I think. When you look at the Greenland Inuit individuals, there was an observation that began, folks kind of started paying attention to this as we understood nutrition science a little bit better then. And in the late 70s, what was seen was this observation of low death rate amongst the Inuit, and it was felt to be related to high fish consumption. Then the Netherlands, those individuals took a look at this, and in 1985 published information from a 20-year observation looking at men who ate fish versus those that didn't. And it's 30 grams of fish a day that they were eating. And it was a 50% lower death rate in those that ate fish up to 30 grams or 30 grams or more, shouldn't be up to, versus those that did not. And then we get to the GISI Prevention study, which was reported in 1999. So these individuals, I mean, look, you're going to get a little bit more familiar with dosing, but what they used was 1 gram of fish oil, which really meant 850 milligrams of omega-3, which then meant there was a 1-to-2 ratio of EPA to DHA that was combined inside that. So really low doses when you think of Reduce It and Gellus being nearly 1,800 milligrams of EPA. But nonetheless, they actually saw a 14 and 20% relative risk reduction in this group. So the race was on at this point, and shortly thereafter, we get the 2002 American Heart Association scientific statement. Now, Dr. Neil Stone did a report in 1999, but this was the actual scientific statement from the AHA, and they recommended omega-3s, EPA and DHA in particular, 2 to 4 grams a day to reduce triglycerides. So somehow we moved from, protecting against death, MI, and actually arrhythmias to, well, maybe we'll just use it to reduce triglycerides and hope that part of that will reduce cardiovascular disease. So then fast forward to 2011, and you have the AHA statement on triglycerides and cardiovascular disease. And what it really came down to was, well, we recommend treating modifiable factors. There's a lot of reasons why triglycerides go up, not just genetic, but the medications and other comorbidities. At that point, if the triglycerides remain greater than 500 after modifiable factors are treated, then you add prescription medications. But in this case, it was really everything but omega-3s, including niacin, which Laura talked about. And really the point was to prevent pancreatitis. It was not to reduce cardiovascular disease. Now, interestingly, they discussed Gellus, and they said, well, we would consider the Gellus results, but we don't think it's related to triglyceride lowering. Here's a foreshadowing. Because, as Laura said, Gellus didn't really have a high reduction in triglycerides. It was like 5 to 9% while you were on 1,800 milligrams of EPA. But since 2004, kind of in this space here, multiple FDA-approved prescriptions were made available for omega-3 agents, and they were almost all combination agents of EPA and DHA. Although Gellus used Icosapent Ethyl, was not FDA-approved here. They were using it in Japan. So evaluation of FDA prescription omega-3s, when when these were all FDA approved, it was really for triglyceride lowering, and we saw that it can lower 20 to 61% triglycerides. And actually, that's higher than what I've seen in terms of triglyceride lowering, and that's what is actually higher than what Gellus saw, and Reduce It was probably around 20, 21%. So here's the omega-3 trials. I show over here on this side. Look at the study names: Vital, Ascend, Strength, OMEME. It's not by accident that they're in white here, because those, here are their doses. They had EPA and DHA combined. And if you looked at Vital, I mean, these are large studies, right? 25,000, 15,000, 13,000. OMEME was smaller, but the cohort was those that have just had a heart attack. And I think it was, I'm going to get this wrong. I think it was in the Netherlands. But here's the 1 gram, 4 grams, 1.8 grams. It's very difficult to find how they're broken down. In particular, Picasol was used in the OMEME trial, and it's very hard to pinpoint what was in it. But again, you have 1 gram, but it's 840 milligrams of omega-3, which is then further broken down into EPA, DHA. Vital and Ascend used the same medication. Then Strength used Epinova. I mean, you can see 550 milligrams, 200 milligrams, but they went to 4 grams per day of their capsule. So what that really meant was the total daily dose was 2,200 milligrams of EPA, except that had DHA also with it. That becomes a little bit important, actually really important later. But in the least, you would have thought, wow, you know, Gellus had 19% relative risk reduction, Reduce It had 25%. Wouldn't you expect at least a 19% risk reduction here in Strength, given that it had the same EPA or more? However, it's tagged with DHA. And I think that that's a pretty good explanation. Well, we'll go into it. Here, down at the bottom, are the EPA-only studies. So Gellus was a large-scale trial, open label, looking at 300 milligram capsule, 2 caps 3 times a day. So it was 1,800 milligrams of EPA. Reduce It, 1 gram capsules, 2 tabs twice a day. So you ended up with 4,000 milligrams or 4 grams. And here you can see that they reached their primary endpoints, statistically significant. Although again, the argument here is that it's an open label and it was not blinded at all. Also, just a tidbit for you, the Japanese population, their average, their baseline pre-treatment EPA was nearly 90. So it was much higher. Reduce It, the baseline was 26 for all that were enrolled. So again, this is the big difference, is no DHA involved in Gellus or Reduce It. So it was such a fantastic result that almost immediately we saw the medical societies recognize Icosapent ethyl is the form. It's an ethyl ester of EPA. So that's the generic name, I guess, that you can call it by. But you can see all the organizations that quickly saw that IPE or EPA should be incorporated into guidelines and assimilated quickly because of its benefit. So here is the non-American, right? I shouldn't differentiate that way. This is the international guidelines that also did the same and incorporated Reduce It results inside their guidelines as well. So as we get to the primary endpoint here of Reduce It, I did so it's only fair that I look at this the same way that I looked at Odyssey. Is there still residual risk? Yeah, there's a lot of things that are happening within our bodies and how atherosclerosis works. So, if we take this across, even at the 36-month mark here, you're going to see that it's still a cumulative of 12%. It's interesting. So let me define that cohort for you. 90% were on moderate to high intensity statins, and the median LDL was about 74 milligrams per deciliter. But the cohort, 60% had type 2 diabetes, hence why the FDA decided to allow that as one of the indications. But 70% had ASCVD. That's the whole cohort. There were a lot that had both. These were high-risk groups, and they had to have identified and verified events prior to being enrolled if you were enrolling through ASCVD. But here we see that it was a 25% relative risk reduction. Again, the absolute risk is a little bit lower, but that's what that absolute risk is right here. And the number needed to treat is 21. I'm always happy to hear Dr. Bott report out the p-values. It was statistically significant. Let's leave it there. But they don't just have one event, right? Our patients have more than one event. We're trying to prevent the first event, but they're more likely to have a second event. And that's what this shows here. So this is the first and subsequent events that occurred in REDUCE-IT. The original data is here, the first event, and you can see the hazard ratio was 0.75, so a relative risk reduction of 25%. But as you see on the second, third, and fourth events, much less occur, or many less events occur in those that are on Icosapent ethyl. So if you went back to this slide, this is time to first event. And then if you started to add events on, this gets wider and wider and wider as these break off. It's harder to show it on a Kaplan-Meier when you're doing subsequent events. But this widens quite a bit when you start looking at subsequent events. So yeah, we know that 23% of these individuals still had an event on high-dose statin with an LDL that was at 74 on Icosapent ethyl. Events still occur, but they occur less as you move on through time. So you don't throw it away. You recognize that Icosapent ethyl is helpful moving forward. So hopefully I've made the case that it's not really about the triglycerides. Or maybe I've started to make that case. So despite its place in the triglyceride guidelines, the MACE benefits of EPA, in this case Icosapent ethyl, aren't explained by a triglyceride effect. So this is busy, and I apologize. It comes from the paper itself, the New England Journal of Medicine paper from 2018. But if you look at the subgroups through here, that unity line where you want folks to be Icosapent ethyl is better, look how astounding that is across multiple subgroups. Now here, this is baseline statin intensity was low, maybe suggesting that they're lower risk in this high risk group. But I point you to this area, which you can't see until I do this. So here's the baseline triglycerides, greater than and less than 200. And there's no difference. It wasn't about the triglyceride level at baseline. Even down to greater than 150 versus less than 150, you can see that the net benefit is towards having Icosapent ethyl on board, regardless of where you started with your triglyceride. It did lower a little bit more, but that's not where the story was. So I'll come here to what was reported by Dr. Bott at ACC 20. And I'm hoping the paper is published soon here. Maybe Matt Ito will give us some idea on that. But here's the baseline and achieved. So Icosapent ethyl placebo. Here, it didn't matter where you started on your baseline EPA, whether it was primary composite you were looking at or secondary composite, but whatever you ended up achieving, I mean, whether it was, less than 20, which is really low in terms of EPA levels, to greater than 34. So these people probably were taking some type of supplement or eating fish. But in any case, if you were able to get their EPA even higher, they received benefit. Jealous is the example here, where the Japanese population had 90, not 20, not 20 to 34, not 34. Their baseline was 90, and you added 1,800 milligrams and saw a 19% relative risk reduction. So here, it looks busy as well, but let me just show you Icosapent ethyl. here are the visits, baseline, 1 year, 2 year, 3 year. So at baseline, both placebo and icosapent ethyl were at 26.1, so fairly low. But look what happens when you give 4,000 milligrams of EPA. It jumps nearly 400%, nearly 500% at times here through their course using 4,000 milligrams of EPA. Here's their last visit, and then on treatment EPA daily average. So what does that mean though? For me, what it means is that I need to track EPA levels. So I need to know baseline and I need to know what they achieve. It's similar to saying, what's their baseline lipid, LDL, and then did they achieve lowering it? So here, primary and key secondary composite endpoints, along here is the hazard ratio. So lower is better in terms of event. And then here is the average EPA that was achieved. And you can kind of see, of course, at any point above 26, people are having benefit, but as they get to 100 to 200, 100 to 200, it kind of flattens out just a little bit, maybe improves cardiovascular death, total mortality, but it's really flat after about 100 to 200. So I'm only imputing this. There's no data that I know of that's been published or at least peer reviewed. I think there's something that's in the works for that. But just know that I'm attempting to achieve levels at least above 100, and I don't know that I'm going to shoot for anything past 200 at this point. So the FDA indications, it's based on trial cohorts. These are the data used for application. So if you want to know why the FDA or medications are labeled the way they are, read the trials. Here is the Reduce It trial, and the key inclusion criteria, which again leads to FDA labeling. These were folks with either established CVD or they had type 2 with greater than or equal to 1 risk factor. So, no surprise that that's what we're looking for as we try to find patients that will benefit. Again, triglycerides greater than 150. That's what FDA used. That was the initial set, although the trial did enroll people as low as 135 and they still saw benefit. So it's a little bit different from trial result to FDA labeling. Then down here, this is why we use it, right? Because it met its primary endpoint. So to reduce CV death, non-fatal MI, non-fatal stroke, coronary revascularization, and unstable angina. So here it is. Here's the indication and usage. This is the FDA labeling here. You can see triglycerides greater than or equal to 150, established CVD or type 2 diabetes, plus a few more risk factors. They did 2 rather than greater than or equal to 1. So I hope that makes sense. So let's go to some cases. So I hopefully I haven't spent too much time through the deep dive, but let's get to the case. So, here's a 45-year-old Black female with type 2 diabetes. She's otherwise healthy and no family history of early coronary disease. She does smoke, less than a pack per day, and has stage 1 hypertension. She's on lisinopril 5 milligrams for renal protection, but also for stage 1 hypertension and metformin 1,000 milligrams POBID. What you can see is her her total cholesterol is 200, HDL is 35, LDL 105, and triglycerides 300. This is an errant question here. I apologize. The first question was, do we start a statin? She's a 45-year-old with type 2 diabetes. And if you recall Laura's presentation, this is an individual that should be considered for moderate intensity statin therapy. So you could go moderate or high depending on other risk factors. And I would say that I'm biased towards high intensity. That's where I would go. But then, my question here is, what about the triglycerides? So as Laura stated, first LDL, then we'll see what happens with the triglycerides. We know that statins can reduce triglycerides by 20 to 30%. So in and of themselves, they are first-line therapy in the triglyceride guidelines. So here, I'll help you decide. We decided with the patient to start a moderate intensity dose of atorvastatin 20 milligrams and asked her to come back in 4 to 6 weeks to reassess. Smoking cessation is discussed. She's not ready. And we considered an omega-3 serum level for baseline, given that maybe this is someone that we're going to consider Icosapent Ethyl but we want to start a statin first to see what triglycerides do. So here she comes back, she returns after starting atorvastatin 20, and this is her lipid profile. So actually, let me drop back for just a second. And an LDL of 105, if I start atorvastatin 20 milligrams, I'm hoping it's moderate intensity and that it will reduce LDL between 30 to 49%. If you want to get a wow, how did you know that from your patient, go ahead and call your shot and say, this is what I think will happen with your LDL. Say it before the next LDL comes, and what you'll find is it'll be pretty darn close, and patients will be impressed, and it'll show credibility that you're thinking through this with them. So if you do the calculation, 71 divided by 105 minus 1 times 100, we had a 32% reduction in LDL. So very close to what we expected with the atorvastatin 20, maybe less than what we wanted, but that's pretty close. So the triglycerides dropped too to 210, but not enough to say she's free and clear with regards to these triglycerides. So it did reduce it though by almost the same amount, by 30%, just as we expected, as again, statins are first line here. So did we hit our target LDL reduction? Well, yeah. In this case, there's not really a target per se. The guidelines suggest a 30 to 49%, but I do like to, I'm old school, and I like to hit an LDL target near 70 or less. But in absence of having a target, I'm pretty happy with what happened here. But what about those trigs, AKA residual risk? So it's really not about the triglycerides, but it's a good reason, an excuse to start something that has vascular benefit for her. So in this case, because we kind of discussed it at the first visit, she recognizes that her triglycerides are elevated. She has a lower LDL, but she's still at risk. She's now ready to discuss smoking cessation and ask, what about that EPA we discussed? Because I set her up for it. We discussed it, and I explained that this could be something that is down the pipe. So her EPA level does return, along with DHA, arachidonic acid, several other omega-3s and omega-6s, which I won't go into for the purposes of this discussion. But she's on atorvastatin 20, lisinopril 5. Her EPA comes back 24. Again, this is really close to what we saw in Reduce It as a baseline. Her trigs and everything stay the same. So what was the Reduce It baseline? I gave the answer, 26.1. And then according to Reduce It EPA, the ACC presentation, what would a potential EPA range be that we would attempt? And I gave you my thoughts here, approximately 100 to 200 milligrams. And then she decides to start Icosapent Ethyl. So IPE EPA at 1 gram, 2 tabs POBID, so 4 grams per day. And we ask her to come back to take a look at this. Now, I don't have a firm and fast rule about this, but given that we have kind of these first visits set up and Reduce It, I would bring her back. And my guess is that her EPA would jump nearly 400 to 450% on 4 grams per day. So, I'm hoping that at least she goes above 100. She'll probably hit somewhere around 140 micrograms per deciliter. I'm sorry, I keep mixing this up between micrograms and milligrams here. But the data is there for us. Okay, so let's move on to the next case then. And actually, this is the last case, as I talk a lot. So here's a 59-year-old male with 3-vessel CABG 5 years ago that was associated with an MI. He's able to walk 3 miles 5 times a day. That's a lot. That's an error. Although maybe he's just that excited about exercise without any symptoms. Recently diagnosed with diabetes type 2. So here we are. We've got someone that may be high risk. His hypertension history predates his MI. He's on an ARB, aspirin, and atorvastatin 20. So on atorva 20, total cholesterol is 180, LDL is 103, HDL 40, triglycerides 185. And you should probably get a sense of where I'm leading us here. Is the atorvastatin low, moderate, or high intensity? At 20 milligrams, hopefully you recognize that it's moderate intensity. But then the question is he stable ASCVD or high-risk ASCVD? And in this case, he's had an MI. It was about 5 years ago, and he has diabetes and hypertension. So he rises up into the high-risk ASCVD with a target of LDL less than 70. So in that case, we now have some thoughts as to what to do with this LDL. That's the threshold. If he's still above 70 after fixing or working with his atorvastatin rather, then that's where we add other statin therapies. So do we increase his atorvastatin? And then if so, to what? Are you going to 40? Are you going to 80? Are you going to switch to rosuvastatin 20 or 40? In this case, as I said, I don't mess around with this. The patient, as I discussed in detail, high intensity, moderate intensity, and what to do, he'd like to reduce his LDL because of his MI. He decides to increase the atorvastatin to 80 and will return in 4 to 6 weeks to reassess his lipids. And what do you estimate his LDL will do? So while I told you that high intensity statins, we look at, greater than 50% reduction, we think about the rule of sixes. Atorvastatin 20 going to 40 maybe is a 6% reduction. Going from 20 to 40 to 80 is about an additional 12% reduction in LDL. So that's what we'll expect to see with his LDL. And because I'm the faculty here, that's exactly what happens. So he's tolerating his atorvastatin 80. The total cholesterol drops to 165. His LDL is at 90, which is about a 13% reduction there. And his triglycerides had an 11% reduction. So pretty consistent with what we would expect with statin therapy and up titration. So did we hit our LDL goal? Hopefully through this, you've learned he hasn't, right? And what should we consider next? There's ezetimibe, 10 milligrams, that reduces an additional 20%. We can jump to a PCSK9 inhibitor, which is 50 to 60% reduction, or although there are no outcome data for this, but the bempedoic acid is also dropping 20%, right, in the LDL. So then what do you consider for triglyceride lowering? Do you add IPE and EPA here? And I would say that it sure makes the case for starting that, but we start to run into finances and what insurances will pay for. But given the higher likelihood of greater LDL reduction, our patient decides, you know what, I'm going to try a PCSK9 inhibitor. I'm 59, I've been 5 years after my heart attack. I want to be around, and I now have diabetes. So let's give me the best risk reduction available. He's also very interested in doing Icosapent Ethyl, and so you obtain a baseline EPA level, and it's 30. So it's a little bit higher than what we see in Reduce It, but it turns out he likes to eat salmon a couple of times a week for dinner. So here, we get back to here. He's on atorvastatin. He's now on alirocumab, 75 milligrams on a Q2-week injection. We've asked him to come back after the 6 weeks, the third injection, so we can really see what it does to his lipids. And sure enough, 44. So we've had a 51% reduction in his LDL, and his triglycerides also dropped 18%, not because of the PCSK9 inhibitor, but rather because he has 4 grams of Vasipa on board, which will net him about an 18% additional reduction in his triglycerides. So, these are the two cases. I apologize that we weren't able to do this in a kind of question-answer format necessarily. But what I would say is at the end of this, reevaluate lipids and EPA at least once annually and sooner if modifications are made to lipids or lipid therapy. And so, that's a later slide if you have questions. But I'll go ahead and end there and give Amy back the microphone and see if she wants to introduce Dr. Shivone as well.
Excellent. Thank you, Viet and Laura. I mean, those were spectacular, just content-packed presentations. It was really riveting, and I think will really impact clinical practice. I think folks can take some of these pearls and actually implement even starting tomorrow. So really well done. Always love hearing the both of you present. So fantastic. And thank you for sharing. We are running a little bit short on time, but in the next couple of minutes, I do want to introduce a very honored guest, Dr. William Siobhan. He is here to speak about EKG action. Now, this is a very unique teaching method to kind of do a deep dive into EKGs, and really would love to hear from him as to how he feels that it can impact your practice. And we here at APAC completely, fully support, and would like to turn it over to him.
Well, thank you very much, Amy. Can people see my slides?
You can.
Yes.
Yeah. So the challenge of clinical competencies came out around May of last year. And so the challenge was established by the ACC and published in the JACC. And here's a reference. Hopefully I can share these slides with you. So I had a history of teaching electrocardiography to cardiology fellows. And I actually ran an EKG quiz for fellows at 2 institutions for 15 years. And the method was case-based. It allowed an opportunity for the fellow to formulate answers and present those before the official answers and learning points were presented. And from year to year, I followed 29 fellows, and there was a significant improvement. And I'll show you those data in a moment. I also rounded with nurse practitioners and physician assistants, and they showed me the same improvement in EKG skills when they would take the same quizzes. So in 2019, I said, let me use this method and come up with something called EKG action. Anyway, here are the data. The initial scores of first-year cardiology fellows was somewhere around 57%. After 1 year of taking 20 quizzes and doing them themselves, went up to 72, and there was a small improvement in the 3rd year. So when that challenge was established by the ACC, I got in touch with Laura Ross and Viet Le, your APAC leaders, who had participated in that paper. And I offered my support and was rewarded by a vote of confidence from Laura Ross by her writing a testimonial. So as a result, many PAs have subscribed to EKG action. And one particular group has 32 APPs in a single institution. And this is some of the feedback that I got from the program director. Increased interest in EKG interpretation, constructive competition, and clearly improved skills. So this is just how it worked for the cardiology fellows, and I expect it will work the same way for APPs as it has. So meet the challenge with subscribing to EKG action. You can do it yourself, or you can ask your institution to sponsor you. But let me tell you something else that kind of prompted my asking for a little bit of time here this evening. And that is that there's a white paper that just came out by a company called MedAxiom, which is a branch of the American College of Cardiology, just this month. And it's about how cardiovascular programs can transform their care by optimizing the role of APPs. It's something that is kind of a good follow-up to this challenge that was presented by the ACC. And so I think if there are these increased roles and you raise your skills so you can meet them, I think you'll be serving everybody. Thank you very much.
Thank you so much, Dr. Siobhan. Couldn't agree more. It's actually sort of one of the pillars of APAC, if you will. And I love this idea, transforming cardiovascular care by optimizing the role of APPs. That's what we are, striving to do as an organization and in a national capacity, and very much appreciate this look into, a unique teaching method that's been, proven, and I think would be of a great asset to APPs in our field. So many, many thanks for sharing. And I urge all of the attendees this evening to please check it out. It's EKG Action. And I think you'll find it highly informative and something that you can carry with you through the remainder of your career. That being said, I hate that we did not have time for a live Q&A. It's 5 minutes after the hour, so we are going to say good night at this time. Again, thank you to Viet Le, Laura, Ross for fantastic presentations this evening, Dr. Siobhan for sharing with us at the end a little bit, and also to each and every one of you. So I wish you all a pleasant evening. Please consider APAC as part of your professional home as physician assistants, and we look forward to future webinars and staying in touch via social media. Everyone take care, be safe, have a lovely evening.
Thank you.
Thank you.
All right, let's see here. While we close out, I do have that final slide there for folks if they want to look at it. I thought it was very interesting to understand that these are off the shelf, and this is what it would take, how many you have to take to meet 1,800 milligrams and 4,000 milligrams of EPA. If you're a fan of fish oil gummies, get ready to eat 842 gummies a day in order to get reduced levels of EPA. Although remember that actually all of these have DHA that's also associated with them. So, but here's a slide that I thought you would enjoy.
You might get diabetes from all those gummy bears, but
then you would be also treating it, I guess. All right, so I guess we'll go ahead and close up shop here, and I will have this available as a recorded webinar for everyone, and I won't necessarily close our webinar just yet because I want to